Hi, my name is Ryan Wu, and I was one of the interns for the Exploring the Impact of Environmental and Climate Exposures and Social Determinants of Health on Multiple Sclerosis for the Data Plus Climate Plus project for the summer. Our main objective for the summer was to identify associations between SDOH, environmental and climate stresses with the prevalence of multiple sclerosis. Ultimately, it was aimed at providing for the first time an idea of how these things concretely impact people's health, especially climate change, as that is a new evolving body of literature to study how climate change itself can affect people's health and how that is a present issue. For multiple sclerosis, it's mainly a disease that attacks the myelin sheath that protects neurons throughout the body, which slows communication between the brain and the body. This is one of the areas of interest because it is an autoimmune disease and is a part of our PI's current research studying immune diseases and seeing how they can be predictors of stresses in the environment. For our hypotheses, outcomes, and study populations, our primary outcome was the prevalence of MS by census tract. Our study population was the adults in the Duke Health System, which have been diagnosed with MS since January 1st, 2016. For the variables that we believed would be negatively correlated were spatial healthcare access, education attainment, median household income, and food security. For some positive associations, we were mainly thinking of the percent of households below the poverty line, unemployment rate, humidity, air pollution, temperature, social vulnerability index, percent uninsured, percent Hispanic, percent non-white, average age, and average BMI. And all of these hypotheses were drawn based on our background literature that we went through. For our methods, we broke it up into three phases. The first phase was gathering and cleaning the SDOH data and climate exposure data and making sure that there were no null variables and making sure that we had data for all the census tracts, or we aggregated it by individual points and took an average for the case for average age, average BMI. And for phase two, we joined that data to our MS prevalences and we drew correlation plots to remove correlated variables that might interfere with our Poisson model. And the ones that we removed were median income, education attainment, unemployment rate, and percent below the poverty line because they were excluded since they were correlated with the social vulnerability index. And finally, for phase three, we generated our Poisson regression, quasi-Poisson, in a Carl-LaRue spatial model, which allowed us to examine the associations of all of these variables. As for some of our key results, you'll see some of the heat maps or the choropleth maps that we had generated of the significant variables in the area. The main results that we found were that the number of days in summer of 2015 with a daily high of 95 or above was quadratically associated with MS prevalence. Negative associations, the key statistical significant one was social vulnerability index, which we found to be a little bit interesting, mostly because one would think from all of our prior literature and just kind of intuition that as someone becomes more socially vulnerable, they are less and less likely to have MS. And so some of our thoughts about that would be maybe is an issue with our study design in that our MS patients were drawn strictly from the Duke Health System, and perhaps individuals who are more socially vulnerable may not be seeking care from the Duke Health System, as Duke is not the only hospital in the county areas that we limited it to. And then for the positive associations, those were the percent uninsured and percent not white in age, which all makes sense as there are more uninsured individuals, more non-white individuals, and older individuals. They are more likely to have MS, which made sense to us. And so finally, for just some general flaws, temperature calculations were interpolated from satellite data to 1 kilometer square grid, so it may not have been very precise. Patient data was aggregated from the MS patients that we had. So those variables of uninsured, non-white age, all these were drawn from that. And then same with the PM 2.5, it was interpolated from stations. Thank you very much.